Hi, good evening, everybody. A very warm welcome to you all to tonight's ThinkIn, which we have partnered with TTP to put together. And it's a ThinkIn that when I started the journey, I knew almost nothing about. In fact, it took me 2 conversations with the people who work at TTP to really explain what it is that they do and what the key questions and considerations are for all of us, for our health and well-being individually and collectively, and related to the kinds of things that they are building in their exciting organisation. My name's Liz Moseley. I haven't done a ThinkIn for a while, so be gentle with me as we ease our way into it. The question tonight is whether innovation in health tech in particular is having unintended consequences for patients. There's all kinds of interesting, exciting things that obviously are possible now in relation to how we stay well and get better, how we manage our own healthcare conditions out of our phones often, and how we get access to those exciting new therapies. Are they safe? Do they work? All of that stuff is kind of on the table for us to try and pick over tonight. And we're joined by an esteemed panel of people who you'll be pleased to know do know what they're talking about, that I'm going to ask the dumb questions to hopefully help us all to sort of maneuver our way through. As always in a ThinkIn, for those of you that have done one before, you know the drill. If it's your first ThinkIn, and we have got quite a few first timers here this evening, the point of a ThinkIn is for you to join in. We'd like to hear your experiences of using this kind of stuff, concerns if you have them, ideas, maybe you work in the industry. So we're very, very keen to hear from you. And there are a couple of ways you can do that. You can either stick up your little blue digital hand. You can find it if you press the participants button, or better still, weigh in the chat where my colleague Luke is kind of corralling your comments, and I will try to pick out interesting and useful questions and ideas from people in the floor to make sure we have a rounded conversation. So without further ado, I'm going to kick off with our first invited expert, who has, without doubt, the best name of anybody who's joined us on a ThinkIn. He is Dr. Dan Strange, and he is one of the people who works for TTP. And Dr. Dan is joining us here this evening. He's business development leader for healthcare solutions, and is a doctor, but not of the clinical variety. He's a doctor of other types of things. And Dan is going to hopefully explain to us, if you can, the scope of what we're talking about this evening, Dan, because we're particularly interested in a field which is called digital therapeutics. So this is not a conversation about the technology that you use where you go to see your doctor, but you see your doctor on a Zoom call or whatever. This is particularly about medicine, effectively, that is software. Could you just sort of unpack a little bit what we mean by digital therapeutics, please?
Sure. I mean, I think that's exactly right. A digital therapeutic is a digital tool to deliver a proven therapy that's regulated in the same way as a medical device or a prescription drug. I think, you know, digital therapeutics, we're working on one called at the moment, which is designed to treat mental health disorders like borderline personality disorder, using a therapy known as DBT. They often have the look and feel of an app. So people think that it's just an app, but actually it's like the difference between a nutritional supplement and a prescription drug. A prescription drug has to go through a full regulated process to really ensure that at the end of the day, it's safe and effective and delivering a safe and effective treatment to patients. And that's what digital therapeutics are doing. I think one of the things that's really potentially transformative out of these, about these types of tools is the scale that they can potentially reach. In mental health, you know, one in 5 people suffer from a mental health disorder. And if you look in the US, about 14% of patients are on antidepressants. With the best will in the world, you're never going to get the sorts of scale needed to deliver personalized therapies to patients, even if you trained up all the therapists in the world without going through a digital route like this.
So let me just understand properly. the difference between, I understand the analogy, there's a sort of vitamin supplement that I might buy at Holland and Barrett and take, don't need a doctor to prescribe that for me. I know that it's safe, versus a sort of medicine that a doctor would have to prescribe for me. I understand the analogy, but there are lots of apps available that would help me to manage a condition that I may have had diagnosed by a doctor, or I might diagnose myself. It might be insomnia, or it might be a weight loss program. And actually, funnily enough, I was doing some research for this conversation yesterday, and I encountered there are many lists of digital therapeutics that you can find if you do a little Google search. And in this particular list was an app called Noom, which is a weight loss app that I know about because I've done it. I'm no longer on it. But that to me, and that was listed as a digital therapeutic, but that to me didn't feel like a medical product. So how do I tell the difference as a patient/consumer?
I mean, I think that's one of the challenges. Is there is a blurry boundary between the types of things that you might just get from the App Store and a digital therapeutic, which is prescribed by your doctor to treat a condition. I think when developing these types of products, say for example, we started off by working with. We have a network of clinicians, and so going out to a clinical doctor who's a specialist in borderline personality disorder, and actually working out what really is needed to what actually makes that an effective therapy. If you think about a drug normally works with a mechanism of action. Someone knows how it's actually affecting parts of your brain, your pharmacology. A digital therapeutic is aiming to act in a similar way. There's a mechanism of action which you have to go out and actually show that you are affecting that, and you are delivering the therapy effectively to patients. At the end of the day, developing clinical evidence to show along those lines.
So you wouldn't be allowed, if I decided to create an app to help people to manage their insomnia, I'm just making this up, I wouldn't be allowed, what is there in place to stop me from making a claim that it will cure your insomnia? That I haven't got a team of clinicians, I've done no trials. I'm sure the app is not dangerous in any way, but it's not going to help you either. Like what is the framework for sense checking that?
Well, I mean, and the fact you say it's not necessarily dangerous actually in any way, it's some of the thinking like that you really do need to do for a digital therapeutic. There's lots of apps out there which are actually potentially, they do potentially have unintended health consequences.
Okay.
A digital therapeutic has gone through a regulated development process. It's been approved by a regulator at the end of the day to show that all of that work has been done to prove that it is safe and effective.
And what would be some of the unintended consequences of an app that says it's a nice thing that you can use, it can supplement, you might take a Calms, you might have a chamomile tea, and you have your app to monitor your sleep? What sorts of unintended consequences would we mean for something like it? Seems so anodyne in a way.
Well, say it's for a mental health disorder. So take and you're actually having a mental health crisis. You turn to your digital therapeutic, or you turn to your app to deal with that. A lot of the thinking that we did is, how do you deal with that actual situation where someone is having a mental health crisis, they need help? How do you ensure that they get the help that they need? How do you put them in contact with the right people at that point in time, which is a very specific point in time, to ensure that they're not left stranded, they're not given misleading advice, which potentially could go down a very different direction.
Yeah, cool. Thank you very much. That's an excellent start point. And there's lots of questions already in the chat about regulation and process and things. So I want to get under the skin of that properly when I come to Lord James O'Shaughnessy in a moment. But before I do that, I'd like to have a quick chat with Dr. Sam Roberts. And Dr. Roberts is with us. She's Managing Director of Health and Care at Legal and General now, and formerly at the Accelerated Access Collaborative, which is a sort of umbrella organisation health innovation, that works at the NHS or inside the NHS, I think. And Dr. Roberts, you're a clinical doctor, aren't you? You're not a PhD type doctor. You're a practitioner.
I'm both. Yeah.
Yeah. Thanks so much for being here this evening. I wonder if, picking up on what Dr. Strange was just talking about, what do you perceive to be? We're going to come on to regulation in a second, but if I'm creating, I don't want to say magical, but if I'm creating a technical solution, a digital therapeutic that is designed to help somebody with a diagnosed medical condition, maybe it's a mental health condition, or a sort of ADHD, one of these types of conditions that they can be used for. How do I, as a patient, access that thing? How do I know it's there? Because it's quite new, so there must be some barriers in the way of me getting my hands on it. What are some of those things that would prevent me from being able to get my hands on it? Is it fair, I suppose, is the question.
Sorry, are you saying how are we protecting patients from getting their hands on things that could potentially be harmful, or are you saying what do I look at to check that it's not, that it has gone through all the kind of regulation that Dan was talking about?
That's also a good question. I think we should definitely handle that. My question to begin with was more, if I'm a patient and I could benefit from it, can I get it? Was my first.
Okay, great question. Yeah, so I think this is one of the areas where the health system is probably lagging what the technology can do. So, for example, there are a range of technologies in weight loss management, such as diabetes prevention, a range of technologies in mental health management, and not all of those are necessarily routinely available like a hip operation may be. So it sort of depends on some of the either the national policy work or the local commissioning. So a great example of where I think it's been done really well in the UK is around diabetes prevention. We've had probably the biggest national diabetes prevention rollout that has been in-person kind of behavior change programs as well as digital programs. And then that allows people around the country who may have be in a state of pre-diabetes, so be just before you're kind of diagnosed as diabetic, being able to access these technologies that are prescribed, exactly as Dan was saying, by their GP. So that's in some cases. In other cases, there may be technology that could help with supporting anxiety and depression, but it's not routinely commissioned either nationally or locally. And there are a number of barriers that can get in the way of some of the best of these technologies getting commissioned and therefore provided to patients.
What sorts of things would put the kibosh on these technologies making their way to the people who need them or would benefit from them?
Yeah, so I mean, there's many barriers and lots written about this, but my top three would probably be evidence, technical challenges, payments, and getting it to work within the clinical process. So I'll just quickly describe each of those.
Yeah.
So on evidence, it's a little bit like what Dan was saying, and there's lots of talk in the chat about it, which is absolutely right. The MHRA and notified bodies would give a mark to a digital therapeutic to say this is CE marked, which means that it is safe to use roughly. But what it doesn't say is whether it's effective. And both in my role at NHS England and now as an investor, the thing that I most commonly see is digital technology developers thinking of digital therapeutics like it's a consumer product. So it's almost for the customer to decide whether it works or doesn't work. But actually that sort of abuts against this very strong tradition we have of evidence-based medicine, where in medicine we only prescribe things if we know that it is efficacious in a broad variety of people over a reasonable period of time in a statistically significant portion of that population. Yeah. So I think that's one of the issues, is people getting the right level of evidence. The second thing briefly is the technical challenges of integrating this new type of therapeutic with an existing system. So for example, it may have to integrate with the existing hospital IT system or the existing GP IT system, and that is not straightforward. The third thing is integrating it into the clinical pathway. a digital therapeutic doesn't just plop into the way doctors and patients and nurses all interact and work perfectly. It often requires some redesign around it that's not straightforward and just requires kind of change time. And then the last is reimbursement, where we do have specific payments for digital products, but they're in the minority. And so most of the healthcare payments are for an episode of care where you see somebody in a hospital or in a mental health trust. So those are the 4 things that kind of get in the way of them being the best.
Others that we didn't have time for. So there's lots of reasons why they could be preventative. When we were trying to think about how to frame the question this evening, one of the things we weren't sure about, and I'm still not sure about actually, I'm going to come to Lord O'Shaughnessy in a sec to get under the skin of this regulatory context, is whether the sense is that the innovation is moving so quickly that unsafe or fake products are finding their way into people's lives and medical histories that shouldn't be there, or whether the innovation is being held back because the barriers to it making its way to people's lives and medical histories where it could really be beneficial is stopping it from doing its job. I wasn't sure if the sense was where it's racing out of control and we need to rein it in, or whether the sense was we need to try and get these barriers out of the way so that we can really make a difference to more people's lives. Do you have a sense of which of those things is true? Maybe they're both true, I don't know.
I mean, as always in life, right, they're both true, but I'd say the balance is on the latter rather than the former, because I think there are some really fantastic digital therapeutics which, you know, have an evidence base and can be incorporated into a clinical pathway, but it's quite tough for our systems to accommodate them for all the reasons that I said.
Yeah, brilliant. Thanks so much, Sam. And I'm going to come to James now, if I can, Lord O'Shaughnessy, who's here to take the tough questions. I hope he's ready, and you'll have seen the chat. Thank you very much for
following it closely. Yeah.
Could you just give us a sense of who is regulating this stuff, and what are the considerations basically for the regulation? Do you have a sense that regulation is behind the curve? Is it doing its job? Where are we at with that? What's your reading of it?
Well, thanks, Liz. Like everything in life, it's complicated, right? So I think the first point is to say that, you know, we have had new technologies in healthcare since, you know, time immemorial, and they might have been chemical technologies initially, or they might have been biological technologies, and now they're digital technologies. So we can actually learn a lot from history about how we have sort of behaved in the past. And I think you also have to take a sort of philosophical position, right, which is, so where on this spectrum do you lie? Are you a fatalist, a sort of pessimist, technologies inevitably go bad? Are you an optimist, technologies inevitably go well and they just need to be unleashed? Or are you somewhere in the middle, enthusiastic but realistic, which is boringly where I put myself? And I think that's quite important because it does actually determine what approach you take to these things. And particularly with something like digital therapeutics, which is complex for reasons we can get into. But it's important because you need to do 2 things. Firstly, as Sam said, there are barriers that you need to remove, and the regulatory ones are good ones. Not that you need to reduce regulatory barriers or make it easier, in fact, possibly the opposite, but that you need a suitable regulatory environment that actually works for digital therapeutics. So that isn't one we have particularly at the moment when it comes to the licensing side. So that's done by an agency called the MHRA. But it is something that the American regulator, the FDA, has done very well, and is an area where I think we're going to catch up quickly. So that's an area where you can actually provide a kind of a more fertile ground, and of course you can skill up your workforce, you can make sure you have the right digital infrastructure, and so on. But at the same time, you also have to make sure that technology is aligned to societal goods. And I think generally speaking, we go wrong with technology, and maybe this is just because I finished watching The Social Dilemma last night, but we go wrong with technology when it is not aligned to societal goods, when it has its own kind of momentum that is uncontrolled and perhaps producing societal harms. And so that for me is the kind of where the regulatory bit comes in, because regulation sounds boring when you just call it regulation. But if you think about it as the opportunity to align technologies or anything, frankly, with societal goods, then it becomes a sort of more interesting topic. And that for me is the big opportunity. Now, what does that mean? What are some of the things that I guess that we'll get more into this? You know, I like your provocative title of unintended consequences, but there are things that we know are potentially risky and we just need to be aware of. I don't know if they're unintended consequences, but things we need to be aware of. A good one, which is a good place to start, is kind of equity and access. You know, there are definitely age dimensions to all technologies, and that applies in healthcare. There are also racial ones as well. I'm doing a project with Imperial College at the moment for NHS X, which is one of the NHS bodies, and a charity called the Health Foundation, looking at how data-driven health technologies can exclude people from Black minority ethnic communities. And they can be things like prejudices in the coding, which you don't even know they're there, but all prejudices that just flow through from kind of analog care. So there are things that we need to be, you know, I guess my overall pitch is you need to be enthusiastic but realistic about these things. And if you put the right things in place, then you can get the most of them.
Thank you very much. I'm sure we'll come back to some of the points shortly. I'm going to take some questions and perspectives from the room before we go to my colleague Patricia, who's going to talk us through the slides that you saw at the beginning. Is Matthew there, Matthew Chisambi? Because you've been making some really interesting comments. I think I'm interested to know about this Orca or Orcha company that you've mentioned, about organisations that sort of list what there is and somehow sort of rate and review. Are you there, Matthew?
Yes, I am. Good
Hi,
evening,
Matthew.
everyone.
Do you work in the industry? You seem to know tons about it.
Yes, so I work for an organisation called Imperial College Health Partners. So we are not a hospital, we don't give care, we are not a university, but what we do is we try and help the NHS and industry bring in innovations to the NHS.
Great. Just talk us through a couple of things that you've posted in the chat, because I was interested in that Orca or Orcha. I don't know if that's how you say it.
Yeah, so I think it's Orca, but you'd have to speak to one of them. But in effect, what they've tried to do is, I suppose, help support that gap between, we have a huge number of apps in development, but we have regulatory processes which weren't really fit for purpose. As I think other colleagues have talked about, a lot of the approval mechanisms within healthcare are borrowed very much from medicines and drugs, and due to lots of issues which we've had in the past, for example, drugs like thalidomide, which have really impacted on babies being born, we have quite a precautionary and safety first aspect on that. So what Orca tried to do is add capacity to the system. You have so many apps being generated all the time, so what they try to do is use their resources to provide an assessment of those apps, and then they give them overall score. So that's, I suppose, the main thing about my understanding of Orca, but then there are also, the NHS have tried to mimic some of that. So the NHS has its own NHS apps library, which gives you kind of NHS validated apps, which are deemed to be of useful worth. But I know that kind of process has been taken over by NHS X, and they're changing how they do their assessments.
And so do you have a sense as to whether in that list, as a sort of, to the untrained eye, I could go into a list and scan it and kind of go, okay, so this app is a legitimate digital therapeutic, it's had a clinical testing regime, is it as easy as a sort of, you know, a soil kite mark on a organic vegetables, do you know what I mean?
So I think for me, this is where the importance of the NHS brand really comes in. So if you go to the NHS apps library, I think lots of people have trust in the NHS.
Yeah.
And I think reasonably so, but I think that's why it's even more important to have transparency around what the assessment they are doing, because ultimately the NHS as a public organisation should represent our views. I think what perhaps is stopping some of this getting mainstreamed, in my opinion, is actually the ability of GPs to prescribe some of these apps and to try and make it more mainstream. And actually, so for those that don't know, GPs are able to click a few buttons on their GP system to prescribe a specific medicine. It would be great if at some point for really validated apps they're able to do the same.
I just wonder if there is a I don't know if there are any practicing GPs here this evening. If there are, I'd love to hear from you as to whether you sort of feel like you know what you're doing with these apps, you know what's available, you know. I'd love to know, because there's a slide actually, in fact that might be a segue to go to Patricia, that talks about or that quotes some research with doctors and medical professionals about the degree of sort of training and awareness they have about this stuff sort of in the curriculum. And Patricia, if you're there, should we run VT on the slides, as it were?
Yes, hi everyone. Thanks again for joining us. So the digital healthcare industry has obviously received a huge amount of attention during the pandemic. There's very much a global spotlight on the industry as everyone kind of seeks to relieve pressures on the medical systems. The third quarter of 2020 alone has seen investments in digital healthcare rise by more than 100%. And as we've discussed today, digital therapeutics is a huge part of that growth, or a part of that growth anyway. Though it currently represents a small part of the digital healthcare space, we can see in this chart that the market value is projected to triple by 2025. And governments are helping accelerate this growth. In the US in April, the FDA temporarily waived requirements around digital health tools so more patients could access healthcare. And digital therapeutics have also expanded in the US as part of Medicare, so they're inching their way into the mainstream, I think, thanks to the pandemic. If we could go to the next slide, please. So doctors point out many potential benefits of digital therapeutics. A study by IBM found that 2/3 of medical professionals think that they will allow for individualized therapy and greater patient engagement, and around half see potential for improved outcomes and in particular reduced cost of care. But as we can see in this chart, and as Matthew touched on earlier, there's still a long way to go. Like, across the spectrum of digital health, surveys suggest that doctors aren't getting sufficient training. Again, as we can see in this chart. The issue is particularly acute when it comes to digital therapeutics. A 2020 Ipsos survey found only 24% of medical professionals had heard of digital therapeutics before taking the survey, and just 23% had prescribed a treatment. Again, as you said, Matthew, there are barriers around that could be considered a digital therapy. So there's still work to be done in that respect. Next slide, please. And so smartphone penetration is almost at 90% in the UK, and it's rising annually. And sales of other mobile devices are also on the rise here in Britain. More than 1/3 of millennials own a smartwatch, for example. And what we're seeing in this chart is that medical researchers are trying to leverage the popularity of mobile devices to conduct clinical trials in the healthcare space. It's quite a natural fit. Medicine and mobiles are mutually reinforcing each other. Of course, this means that digital therapeutics may benefit some more than others. People who don't own such technology, particularly in the UK, tend to be older or financially disadvantaged, and therefore often also more likely to be the people who need better access to healthcare. Next slide, please. And of course, there are barriers to the adoption of digital therapeutics, and trust is one of the biggest. People are hesitant to share their data. In early 2020, so before the pandemic had really hit Europe or the US, a Deloitte survey showed that people were less willing to share their data than they were in 2018. This was for healthcare research purposes, with their doctors, or even with emergency services for life-saving treatment. But what we're seeing in this new research and on this chart, which was conducted post-pandemic, is that attitudes towards healthcare data are changing. People feel more willing to share their information if they know it might take them, it might make them healthier or save lives, whether that's their own life or someone else's. Obviously, the numbers are low for things like tech companies, but they are growing. And of course, there's other big motivators that might drive people to get involved with digital therapeutics, including how convenient they are. If we can go to the next slide, please. So as Daniel touched on earlier, the first cases of digital therapeutics are in mental health. And speaking of convenience and accessibility, the potential benefits of this technology are really big for both consumers and healthcare providers and kind of everyone in between. Poor mental health costs UK employers about 45 billion a year, according to Deloitte. And as we can see here, the mental health crisis is accelerating in Britain. Most people are seeing for an initial appointment within 6 to 18 weeks, which is already quite long. But then there's a further increasing delay for those who need follow-up treatments. And the NHS is not releasing current figures, but I think it's fair to imagine that the wait times have probably got worse because of COVID. So as we mentioned in the last slide, digital therapeutics could offer much faster turnaround for treatment, or at the very least help manage symptoms. And there's other potential benefits, which I'll let the experts talk about, but digital therapeutics are discreet and there's less stigma attached to them compared to treatments like therapy or drugs. So there's potential for disruption in that sense as well. That's it from me.
Brilliant. Thanks ever so much, Patricia, there was a lot in there, and the chat's been going crazy. So I'd like to come to Chris Dabbs next, if I can. I'd love to hear from Lynn, picking up on the point about, well, I just like what she said, I'm all sick of apps, what happens to good old talking therapy? I think that'd be interesting to hear from too. And then perhaps we might hear from Andrew Girdwood and Adam Giangracco if we can. But first of all, Chris Dabbs, are you there?
I am.
Hiya, Chris. Oh, nice to see you.
Hello.
How's it going?
Not too bad, thanks.
Just fill us in on what you're thinking with all this.
I suppose the thing that particularly strikes me is the risk of this approach possibly reinforcing a very individualistic approach to healthcare. So in my own work, we find, particularly when we're working with people with long-term health conditions, they often benefit from socialized approaches, actually working alongside other people with similar health conditions, and hence the development of things like social prescribing and so on. And with some of the language even that's been used so far, I wonder if also there's a distinction to be made between an individualized approach and a personalized one, because to me they don't mean the same thing.
How are they different? Just contrast the two, just so we know what you mean.
I think for me, it's absolutely fine to have an approach which is personalised, that makes sense to an individual. But there's a distinction around, for many people, a personalised approach also involves having social interaction.
Oh, I see. So individual that's specific to me, but that I don't just do on my own, that it requires me or enables me to connect with other people. Yeah,
absolutely. I see. And I just wonder with what we're talking about, if there's a risk that the prevailing culture that there often is in healthcare, which is doctor-patient, nurse-patient, it's very one-to-one, very individualised. Whereas for long-term conditions particularly, people benefit a lot from social interaction and social contact with people similar to them. And I just wonder if this approach is reinforcing that type of mindset.
Fascinating question. Really, a really good point. Chris is basically saying, I don't know if somebody, perhaps Sam or James, you want to sort of respond to that, but how would you build into the sort of, I suppose, the testing and the designing of these digital therapeutics, that social element, particularly with mental health, things that are helping people to manage their mental health? James, do you want to talk to that point maybe?
I think so. Yeah, no, I'm unmuted. I think Chris makes actually a really, really profound point. I mean, lots of medicine, of course, is inevitably individualized. It just is. But it is important to distinguish it from personalization. I mean, one of the great benefits of a digital approach is the potential for much greater personalization. So, you know, if we've sequenced the genome of an individual, we are more likely to know if they've got particular genetic and other markers that will make them susceptible to treatments or not, which is a good thing, right? Because that's going to help more people live healthier lives. But his point is about the sort of social aspect of this is really important, because particularly with mental health, but not only with mental health, there's plenty of evidence to show that people who spend time with other people have better physical benefits as well. But it seems to me this is really a question of design, because it's perfectly possible, or it ought to be possible, to design these features into the technology. So I don't think there's a design flaw or a design problem. I guess the question is, can you quantify the benefit? Because that is what's going to make quite a big difference about whether these things end up, and I think this is where a lot of the chat has gone, being actually prescribed. Because, and I think the move towards social prescribing is a good step here, because we are starting to understand and be able to quantify the benefits of it now that it's spreading out. But perhaps that's something that, when you look at something like NICE, which does the health economics assessments, basically whether things are value for money or not, considering these kind of aspects of a digital therapeutic as being core to its proposition and not just a nice to have could be an important feature.
Yeah, definitely. I wonder about the cost thing as well, thinking about what Lynn said in her comment, which is, I don't want an app, I'd really rather have a talking therapy. And that, you know, on scale, it's probably going to work out cheaper. And I worry that there sort of might be a rush to sort of prescribe the cheaper option rather than the more costly option potentially. But I know that Dr. Strange would like to weigh in on this too. Dan, what's your view on this sort of personalised, individualised? How do we knit it into a broader social treatment?
Well, I think it can be an enabler, like many things. It's how you actually do it. So recently we've been looking at treatments for diabetic macular edema. And this is something where you've got working age people who have to go and get an injection in their eye once a month. Is that treatment. It's a very high burden treatment, and you end up with all these people who are quite disconnected, and unsurprisingly the number of people that actually engage with that treatment over time, there's pretty low persistence with carrying out that therapy, and eventually actually you go blind. So it's a pretty severe thing to manage. But digital tools like digital therapeutics can actually connect a whole range of people together who might be separated out in dispersed locations. I don't know anyone who has diabetic macular edema. I don't know, there are lots of rare diseases out there, but actually when you group all those people with those different diseases together, then it can give them a community to actually get more of that social interaction. So I definitely think, to the point of it could be, if you design it to be individualized, there are challenges there, but it also can act as an enabler to bring in that social element and help connect people together in the way they think about their health.
Yeah, I can see both sides. To be fair, I'm actually going to come to Kevin Flanagan if I can, if he's there and if he's okay to come on screen, because you've asked a precise and specific question that has exercised various people in the chat. Kevin, are you there?
Yeah, I am.
Yeah.
The question is, are you aware of specific failures in digital therapeutics, or are we tilting at windmills? Because I'm aware of one failure, but I'm more interested in what the panel thinks.
How are you aware of one failure? Is that giving the game away?
Well, yeah, it is. Afterwards, I'll see if it comes up. If it does not, you can come back to me and I'll tell you what it is.
I think Sam responded a little bit in the chat, so let's go to Sam to answer that question, and I'd love to know if anybody else has a sense of it. Specific failures. Are you there, Sam?
Yeah, I am. So in my last role, we implemented, I'm trying to count, it was probably about 5 digital innovations. And I think we got better at as we went along. But the first one, the specific failure that we had is that the sense from the clinician was that when the person had left the waiting room and they had prescribed this intervention, it was as good as it having been taken. And when we went back a month later to look at the data, it actually found that only 10% of the people that were prescribed actually ever logged on. Now, this is not unique to digital therapies. This happens with medicines, but I had not ever seen non-compliance of quite, or non-adherence of quite that level. So that just taught us that we needed to implement things slightly differently, that we needed to follow people up, that we needed to check their logons, that we needed to, actually most importantly, incentivize the provider on engagement. And that's a lesson that you'll see now through a lot of the digital therapeutics payments in the NHS, is that they're contingent on continued engagement. So that's my specific example, but we learned how to manage it. I don't know, Kevin, what yours was.
Kevin, do you feel comfortable to share? You don't. There's no obligation if you don't.
Yeah, no. It's I'm working. I'm a digital entrepreneur, working in mental health, and it's only bubbling below the surface, but it's oddly enough not about patient experience. It's about clinician experience in mental health. And what you're getting is mental health services in the NHS have twice the, should I say, the vacancy rates, twice the burnout rates of the rest of the NHS. And digital therapy, most people don't realize the NHS digital mental health services have operated pretty close to 100% capacity all through the crisis. And what's happening is therapists are now burning out from Zoom, because this is much harder to do, delivering therapy, than it is. And there's a reason. Like, I mean, I would turn around and say Occam's razor, video technology has been around for 20 years. It hasn't taken off. It took off for COVID. I don't think it's going to stick quite as much as a lot of people are betting, because, it's been around for a very long time and it doesn't quite work. We're missing a lot of the effective communication we need, particularly when it gets to mental health, where let's be honest, we don't really know what we're doing as well as we might.
Interesting. Thank you very much, Kevin. I'd like to go, if I can, to Andrew Girdwood. I know he's a familiar face on ThinkIn's, because he's making some important comments, I think, about sort of maybe the role of the big tech companies in helping us as consumers and patients sort of navigate our way safely through what is available to us. So we'll come to Andrew in a second. And actually, way back in the chat, I made a note that I'd like to come to Hester McCreary as well, who's a great friend of Tortoise, because she used an acronym that I didn't know what it meant. And I promised myself that if in this ThinkIn I came across words or phrases I didn't know what they meant, I would ask the question. So let's try Andrew first, if we can. Andrew, are you there?
Yes.
Hiya. You made a couple of comments about great hat, by the way.
Thank you.
A couple of comments about the role of the sort of the big tech, the consumer big tech behemoths, but also this thing about community. They're both interesting. So the floor is yours.
Thank you. I've been spamming away, and I don't really know where to start, because this is a big chunk of my life. I have a rare disease. I'm literally just back from the doctors for a blood test, and the nurse is going to drive to the hospital tonight, and I filled the paperwork, and I know this can all be done digitally. I think there is a big thing that the tech platforms can do. I think what we've talked about today is to find a level of excellence, a level of separation between the apps that we're talking about. I want to call them apps, and then what you would get advertised on Facebook. But it's not, as a member of the public, you cannot tell one from the other. Apple and Google can make that happen. Apple and Google can make it easier for the members of the public to find apps that are suitable for us to download and use. Many years ago, Google tried to launch Google Health, and I regret, but also praise the fact that the medical community blocked it. But just having that single source of intelligence, you could quickly check your records, would have been brilliant. But that data is a concern, isn't it?
Yeah. There's the data privacy thing came up in the slides that Patricia shared, and I'm surprised in a way that it hasn't come up more already in the chat. I thought that would have been something that people would have voluntarily said. I would be worried typing in very personal and private details, particularly if I have, I don't know, a mental health issue or something like that, and where it was going and would I trust it? I don't know. Do you agree?
Oh, absolutely. So I've worked on a government official COVID app, and what I come across is a lot of people said, "Oh, I'm not using that. I'm using the Zoe app instead."
Yeah.
Okay, that's fine, but do you know that's a private company? The government doesn't have any access to that data. We're splitting our data pools in a way, and of course, I don't expect the public to know this any more than I expect the public to know that RBS and NatWest are the same entity. It doesn't matter, but it kind of matters to the results, right?
Yeah. Thanks, Andrew, and good to see you, and excellent hat. I think Hester McCree unfortunately has gone. I've missed her annoyingly. I'd quite like to come to Adam Giangreco if I can. He's made a couple of important comments in the chat too. Are you there, Adam?
I am, yeah, thank you.
Hi. Yeah, the floor is yours.
Yeah, so sort of what you were mentioning was the points I made around the user engagement of the different digital therapeutics, and really I think looking to digital technologies and apps and platforms like Facebook that are not universally but much more popular than the vast majority of things that are out there, and that have very high retention rates, and people use them significantly. And thinking around why that is, around what they give back to those users. And I think taking inspiration from that will lead to more compliance and engagement with digital therapeutics. That's not to say Facebook is the way to go and that's what should be done, but that sort of user interface that they provide and what they provide as feedback and people perceive getting something back from them, that's going to be key, I think, for long-term sustainable engagement with digital therapeutics.
It's really interesting, Adam, and the language that Sam used when she was giving her example about the a flaw in the to do with engagement and usage and sticking with it, incentivize the provider on engagement. It just struck me because that's the language I associate with my history in marketing, and we talk about customer communications and engagement. That sounds like customer engagement language from a commercial environment. When that's the metrics that you obsess over, and we're a membership organization at Tortoise. Those are the things that we worry about too. Have people been to ThinkIns? Have they joined in? Are they still caring? All of that stuff. And I'm interested to imagine the sort of healthcare industry having to learn from the big consumer companies how to make people stick with it. It's counterintuitive, but it sort of makes sense if the world is moving in that direction.
I think that's right, and I think there's this much greater element of self-management in a digital therapeutic. You're there on your own. It may be a social element to that digital therapeutic, but fundamentally it's you, like we all are now. You're sitting by yourself in a room somewhere, either with a phone or with a computer, and there's much more of a role of the individual in managing their use of that therapeutic, which I think speaks to what you're talking about around the marketing approaches, the good element of the marketing approach.
Yeah. Thanks, Adam. Nice to see you. I'm going to try. I'm not sure what the real name of this person is. Piers Ricketts Easton, all one word, talking about data. Before we move on, I'd quite like to go after that to Louise Simpson, if I can. Are you there, Piers?
Yeah, so it's Piers Ricketts. I'm Chief Exec at Eastern Academic Health Science Network. So like Matthew from Imperial, we're one of the parts of the NHS that supports some innovation. Just on the data, I mean, it is surprising perhaps it hasn't come up more. Yeah.
So you were saying that the reasons why people, you were suggesting in your comment in the chat that people don't have an issue with their data being anonymized and used in certain scenarios, but it's about who gets the data and how long does it sit there for and how do I know it's safe?
Yeah.
I was fascinated to see in the data that Patricia dug out with, which was that trust, that willingness to share data for health reasons was declining, and then the pandemic hit and suddenly it went up again. It was almost like an acknowledgement on a sort of wider scale that mass data collection is going to be A, required, or B, beneficial. Is that something that you're aware of in your work, Piers?
Not in my work. I suspect the reason for that is bound up with, if you share your data, you might have to isolate, and what's the government going to do with it? The pandemic has got us into some really difficult uses of data, sort of even more difficult than we had before. And I suspect that this worries many members of the public. And it's quite interesting also in this, the distinction between the Zoe app, which, yes, it's from King's College and a private company, but it is NHS funded, and the NHS tracking app, where you're sort of giving up your data. Those are two very different things, even though to many people, it looks as though they might be doing the same thing. One's a symptom checker, one's a tracker. One, the government doesn't have the data, the other one they do. So I think that's probably a specific consequence of the pandemic.
Yeah, thanks ever so much, and nice to see you, Piers, and thanks for being here. I'm going to go to Louise Simpson, and then I've got a kind of what next question that I'd like to put to our invited experts if we can. Louise, are you there?
Yep.
Hi, Louise, how you doing? Nice to see you.
Nice to see you.
I liked the comment you posted in the chat just a little while ago. Would you just sort of take us through what your thoughts are on this?
Well, I sort of kind of feel, for the good of everyone, that actually, I mean, people are going to loathe hearing this, that we all just get chipped. We get chipped at birth, and our medical status is kind of not tracked in a sort of horrible, big brothery way, but in a practical way, tracks our progress through life, our deterioration in different areas. I mean, they're talking about Alzheimer's is now, it can be tracked 20 years in advance. So all manner of diseases from birth. And we just give up the kind of personal side of this. And, the COVID thing, we could end up with our COVID passports or other virus passports within that chip. Now, I mean, I suppose the idea of this may perhaps have come about is, I don't know how many years ago, I got invited to be part of a research program where even if they discovered some fatal disease, They would never tell me about it, but they are tracking my physical, sorry to say it, deterioration. I haven't heard from them for years, which is why I've forgotten their name, and it's probably because I've left the country that they don't get in touch with me anymore. But I just think, for the good of all, something that charts us through life, like a human MOT test, is to me obvious.
Let's put you in charge, Louise. I quite often find that when Louise makes a comment and I just kind of think, well, that just seems sensible to me. Thanks very much. It's nice to see you. I've enjoyed a couple of important comments, actually, and rather questions from Amelia Neville. So before we go back to our invited experts, let's just, if we can find Amelia Neville, who's asking an important question about who gets the data. Is the data shared with insurance companies? You were asking a bit before about cost versus quality as well, Amelia. Are you there? Or it doesn't look like Amelia is there. Let's go back to Sam, if I can, then, with both of those. So Amelia's question earlier on in the chat was, does this come down to a compromise between a more cost-effective, potentially digital suite of options that perhaps are more accessible to more people and therefore sort of over time cost less money, versus a more costly, higher touch, and arguably more sort of fulsome set of treatments? Are we pussyfooting around that as the reality?
So I don't know, this to me feels a little bit like how it felt when we started with ATMs and there was, are all the branches going to close down? No, it's this, every time you open a channel, what ends up happening is you in general get more traffic overall, but some of the channels take some of the volume from another channel. So I can completely believe that, as I think Piers or somebody else mentioned in the chat, that in areas where behavior change is required, such as stopping smoking, exercising, those kinds of things, I can completely believe that quite broad coverage for the whole population of digital therapeutics aimed at that for people at high risk could be helpful. But I don't believe that digital will ever be the only channel for those things. So much like the National Diabetes Prevention Program has an in-person channel and a digital channel, each one will suit different people's lifestyles.
And do you think that patients will be able to sort of request or select if you feel uncomfortable, or if you would rather, if you're disposed to be, do you think that the choice will remain, or do you think ultimately there'll be a sort of funneling into one route or the other?
I don't know, that's tough, right? I mean, the extent to which patients are incorporated in their choices around medical care in general is not great. So my assumption is that this would fall into the same category, but I mean, that is obviously the hope, is that this is providing evidence-based therapeutics to a greater proportion of people because they can engage in a digital fashion where they may not be able to attend in person.
Yeah, thanks, Sam. I'm going to take a sort of a closing question, if I can, to Dr. Strange and to James, which is really about where we're going as a direction of travel, specifically in relation to COVID, right? It is the biggest public health story / crisis / event, certainly of my lifetime and of many other people's too. We've talked about the Zoe app, we've talked about the tracking and tracing app thing. Do you have a sense of where health tech innovation could be taking us in the fight against COVID? Let's start perhaps with James, shall we, and we'll close with Dan.
Sure, yeah, and I think it's good to start with something, it's sort of tension that's been elucidated in our conversation and in the chat, which is, I don't know if you've ever been in the back end of an ad tech company, but what they know about you, your habits, where you are, is unbelievable. Is actually kind of terrifying, sort of thing that the security services would love to get their hands on. And yet, as Piers pointed out, the arguments about the government having access to your data through a tracking app, which by the way doesn't actually track you, doesn't have location services, because that was felt to be too much information to provide to the government. There is this sort of weird disconnect between what we're prepared to give to Google and Facebook and what we're prepared to give to the governments that we should be able to hold accountable. The NHS is fascinating because it actually retains that trust. So if you talk about the NHS being the sort of custodian of your data, people thumbs up. You talk about the guardian, the government being a guardian, then people are generally put off. But potentially, as that data showed, even health services, even our beloved NHS will lose that luster over time. In which case, what's the solution? Well, the solution has to be that individuals become the controllers of their data, and the inquiries have to come to them. Now, this used to be a sort of impossible dream because technology didn't allow that kind of computation, but it is now possible. And so where this goes to, and I think it was Adam who talked about self-care, which is actually the repository of the data is with us, the therapies and the care come to us, and we're much more enabled to look after our own, in a proper way, not in sort of snake oil world, to look after our own health. And by the way, I do think that is the passport of how we get out of COVID, which is using tests and for antigens and antibodies and vaccines and passports and all that to demonstrate that our risk is low to ourselves and to others, and that's how we re-engage in society.
Fantastic, thanks very much, James. And Dan, Dr. Strange, for the closing words. You're right on the front line of this, making these things, these digital therapeutics, working with people that do on a day-to-day basis. Do you have a sense of what a digital therapeutic or similar, a health tech innovation could or should or will do in the fight against COVID? What's the next thing that we can be excited about?
Yeah, so I actually want to move a bit beyond digital therapeutics, because part of it is that passport and things like that, but part of it is actually just how do you actually do those tests faster, whether it's for COVID or just anything. How are you going to get that diagnostic data in an easy to use way for patients? We're really excited at the moment that we're working on a pooled screening machine for COVID, which can be used by anyone, anywhere. Allows you to do 36 tests at once with results in 30 minutes. Actually costs the same cost as a single test for one person. So it's actually a lot cheaper if you look at that. And this type of machine could be put into a school to screen every single student in a class every day in one go. So, think about asymptomatic patients. You could be identifying and isolating potential outbreaks as they happen. So you're not needing to. It's as much about sharing all of that data, but also how do you generate that data really quickly. We sort of think these types of things as well are going to represent the future. Easy to use distributed diagnostics that allow individuals and organizations to manage health security, testing a range of conditions, whether it's for COVID or actually looking forward 5, 10, 15 years in the future for a whole other range of conditions that can then link into a digital ecosystem and at the end of the day, change a lot of the ways in how we manage healthcare.
Thanks so much, Dr. Strange, and if you can just go away and invent that for us, that would be fabulous. Let us know when you're done. I'm very happy to plug it in and keep it going. It's been a really, really stimulating discussion this evening. I hope I've done a reasonably good job of representing the sort of person who knows nothing as an interested observer. Heartfelt thank you, of course, to our invited experts who've kind of kept us on the straight and narrow, Dr. Sam Roberts, Dr. Daniel Strange and Lord James O'Shaughnessy, and to everybody who's turned up and joined in. It was quite meaty, it was quite chewy. I think we've sort of cracked open something. My sense is, ironically, in a year where we've all been obsessed with COVID, we haven't really talked about healthcare and health futures that much. So this evening was a brilliant conversation to get us going. We are planning for the third week in January to do one of our summits, our big full day summits about the future of healthcare and this kind of thing, health innovation, but all the other stuff that we think is interesting. And we will have a good time to do in depth on that day. So thank you so much to everybody who's joined in this evening. It's been a real pleasure. And thank you, of course, to TTP, who've been our partners for today. Have a nice rest of the evening. Goodbye.